Thank you. So good morning, everybody. So my topic is CT in pulmonary artery hypertension. Briefly, the learning objectives: to learn about the CT diagnosis of pulmonary artery hypertension, to become familiar with the causes of pulmonary artery hypertension on CT, and I will show you some illustrative cases. So the outline is going to be very simple. We will see first non-specific signs that make us suggest the possibility of pulmonary hypertension for our colleagues. And then we will see signs that are specific and which help us recognizing the cause of pulmonary hypertension. So the first group of signs can be divided in two subgroups: a vascular sign that we're going to see on the pulmonary arteries, such as dilatation, loss of distensibility if we use ECG gating. And the second subgroup is the cardiac signs that we will see on the right ventricle, showing first hypertrophy, then dilatation. I think that you all know these signs, but maybe it's useful to briefly review these signs. Dilatation of the main pulmonary artery has sensitivity and specificity ranging from 87 to 89%, and it starts with a value of 29 millimeters. The second sign is an increased ratio between the main pulmonary arterial diameter to that of the ascending aorta, and I think that this sign is mostly useful in a young patient, meaning before 50 years old. And the third sign is an increased segmental artery to bronchus diameter ratio in at least 3 lobes. So here you can see visually that the main pulmonary artery is enlarged as compared to the ascending aorta. These are the measurements done in another patient. And here we can see that there is an increased ratio between the diameter of the arteries and the corresponding bronchi. What about the cardiac signs? Right ventricular hypertrophy is defined by thickness of the right ventricular free wall of at least 4 millimeters. Then we can see here there's an enlarged right ventricle diameter as compared to that of the left ventricle. A lateral bowing of the interventricular septum is the third sign, and we can see also reflux of the contrast material into the IVC and suprahepatic veins. Last signs, pericardial effusion. Sometimes it can be difficult to differentiate between the right ventricle hypertrophy and pericardial effusion, but in this patient it's quite obvious there's a difference. And last sign, opening of foramen ovale can be seen if you use ECG gating. In patients who have incomplete fusion of the foramen ovale at birth, it can open if there is a marked increase of the right cavity pressure, and it helps diminishing the high pressure in the right cardiac cavities. But it's not the cause of the pulmonary hypertension, it's the consequence. What about functional parameters? If we use ECG gating, we can have diastolic and systolic values of different structures, such as the right ventricular outflow or the right pulmonary artery. And we evaluated several features in patients with and without pulmonary hypertension, and we found significant differences. The most significant difference being seen for the right pulmonary artery distensibility, and this parameter showed also the highest correlation to mean pulmonary arterial pressure and the highest area under the ROC curve. And we found that with a cutoff value of 16.5%, the positive predictive value was 95% for the presence of pulmonary hypertension on right heart catheterization. This is how we evaluate the distensibility. We need to have two oblique reformation to have a true cross-sectional area, and we need to circle manually this cross-sectional area at different times of the cardiac cycle. And here the distensibility is normal with a 21% value. And in this patient with idiopathic pulmonary arterial hypertension, the value is only 10%. So to briefly summarize, maybe the best diagnostic parameter, if we use ECG gating, is evaluating the right pulmonary artery distensibility. To minimize the radiation dose, maybe we can limit the acquisition to the right pulmonary artery and not to the entire thorax. It's not necessary to use contrast administration because the main right pulmonary artery is very large, but we need to perform manual measurements. So let's move now to CT signs related to each specific cause of pulmonary hypertension. As the previous speaker explained, there are still 5 groups in the recently updated classification, and I will mainly talk about group 1 because the title of the talk is Pulmonary Artery Hypertension. But I will also show you example of group 1 prime diseases and also CT signs that help recognize chronic thromboembolic pulmonary hypertension as a differential diagnosis of group 1 diseases. So this has been already explained by the previous speaker. Group 1 diseases include idiopathic, heritable, drug and toxic-induced pulmonary artery hypertension, and also PAH associated with connective tissue diseases, mainly systemic sclerosis, associated with HIV infection, portal hypertension, congenital heart diseases, except those that were moved to group 2 diseases in the recently updated classification. These are the data of our French National Registry. As you can see in these group 1 diseases, idiopathic cause represent nearly 40% of patients, and connective tissue diseases, Eisenmenger, portal hypertension, and anorexigen each represent between 10 and 50%. Recently in France, we had a major scandal with anorexigen, and there is an ongoing trial because this a treatment called Mediator, which is in fact Benfluorex, was given to patients with type 2 diabetes, even though they perfectly knew that similar molecules in the past had given pulmonary artery hypertension. And it was sort of also political scandal because at the head of this laboratory there were connections to the National Drug Agency. So there is an ongoing trial in France. So what are the specific signs that will suggest idiopathic heritable PAH or PAH due to HIV or anorexigen origin? There are none. No specific CT features. You will only have the vascular signs, such as the enlargement of the main pulmonary artery and cardiac sign, right ventricular hypertrophy, right ventricular dilatation. This is here the case of a 30-year-old woman with heritable PAH. Her father had the condition, and there is nothing more to be identified on CT. This is here the case of a 37-year-old woman referred for suspected PE. She presented at the emergency room of our hospital, and because she was dyspneic, there's always the same reflex, dyspnea, CTPA for PE suspicion, even though the patient had a dyspnea for several weeks and months. And take a look on this chest radiography. You will see, of course, there is a dilatation of the main pulmonary arteries, and there is also another sign, even though it's written in French. Assise means she's sitting on her bed because she cannot be on the supine position, otherwise she suffocates. And this is a sign of very severe pulmonary hypertension. And I think that in this situation, it's quite dangerous to perform CTPA. And she had a CTPA. You see here the major enlargement of the main pulmonary artery. Look at the right ventricle, look at the compression of the left cavity, and following CTPA, she suffered cardiac arrest and she died. And I talked with my colleagues asking if they found in the literature recommendation about not performing CTPA if we suspect severe pulmonary hypertension, and we did not find anything, but it's probably a matter of common sense. If a patient cannot lie down and is breathless, if he does, maybe it's very dangerous to perform such a study, because the injection of 100 millimeter of contrast, the increased volume reaching the right heart, can decompensate the situation. So Nick Scruton already gave you some information about PH due to HIV infection. It is probably underestimated. It requires specific PAH therapy, and it does not improve on antiretroviral therapy. And that's it. Now, pulmonary hypertension due to connective tissue diseases. What are the specific CT features? We will have signs of infiltrative lung diseases, mainly NSIP features in systemic sclerosis, including ground glass, reticulation, and traction bronchiectasis. But in fact, there are different groups of systemic sclerosis patients with pulmonary hypertension, a group with PH-ELD disease, and a group with pulmonary artery hypertension with no signs or minimal signs of lung parenchyma disease. And to differentiate between these two groups, you need to have a look on the pulmonary functional test. We can say that the pulmonary hypertension is due to the infiltrative lung disease if there is a restrictive pattern on PFT. And in this paper from David Launay, he found that this group of patients had a worse prognosis. This is here the case of a 62-year-old man with Crest syndrome, dyspneic. You can see here signs of pulmonary hypertension, enlargement of the main pulmonary artery, enlargement of the right ventricular hypertrophy. Here you can see the hypertrophy. This is here the pericardial effusion. And you can see that there are signs of infiltrative lung disease. But since the pulmonary functional test did not show significant restrictive problems, maybe he has a combined cause of pulmonary hypertension. What about pulmonary arterial hypertension due to portal hypertension? The specific CT features are those related to portal hypertension, such as splenomegaly, esophageal varices, as shown here. And in some patients, you will have aneurysmal dilatation of the central pulmonary arteries, such as in this patient, and in this case you can have in situ thrombosis that should not be confused with chronic thromboembolic disease. In group 1 disease, we also have Eisenmenger syndrome. It was first described in a patient with a ventricular septal defect, but in fact it includes all systemic to pulmonary arterial shunts, and the probability of pulmonary arterial hypertension depends not only on the location but also on the size of the defect. In patients with very large defects, superior to 1.5 centimeter, the prevalence is 50%. This is to explain the physiology. In a ventricular septal defect, you will have first a left to right shunt, and then because there is an increased blood flow through the lungs because of the shear stress, there's an increased pulmonary artery resistance, and at a certain point the shunt becomes bidirectional, and at the last step there's a reversal of the shunt, which defines the Eisenmenger syndrome, and the patient have a right to left shunt and cyanosis. What are the specific CT features? Those related to the shunt, you will detect easily the ventricular septal defect. There are patients with undiagnosed sinus venosus defect, as Nick showed you in the previous talk. And we had this young patient who was an illegal immigrant from Pakistan that reached the emergency room of our hospital, and with, again, CTPA4P suspicion, no physical examination. And you can see here the patent ductus arteriosus, but it's not the cause of the disease, it's the consequence. And here you can see the major enlargement of the main pulmonary artery, and here this large ventricular septal defect, the major hypertrophy of the right ventricle. So no PE. This is another case in an older patient with unrepaired ventricular septal defect, as you can see here, and with very marked enlargement of the pulmonary artery and in situ thrombosis formation. And at this stage, it's not possible to only repair the congenital disease. The patient requires heart and lung transplantation. Group 1 prime is a very difficult group. As previously mentioned, these are rare diseases that we need to recognize because lung biopsy is risky and infrequently performed. In POVD, you have obliteration of the postcapillary veins, and in PCH, alveolar capillary proliferation. So let's start with POVD. It's rare, but most of the patients have an history of hematologic stem cell transplantation. What are the specific signs? These signs are very similar to those of pulmonary edema, thickened interlobular septa, centrilobular ground glass nodules, pleural effusion, and lymphadenopathy. We had this case in a 37-year-old woman who had gemcitabine for metastatic breast cancer. And as you can see here, the CT demonstrates smooth septal lines, peribronchial thickening, not because of bronchial disease, but there is an edema infiltrating the axial interstitium, and very interesting findings, small central pulmonary veins. If this was due to left heart failure, we would expect to have enlarged central pulmonary veins. And the other signs are those related to pulmonary hypertension, enlarged main pulmonary artery, pericardial effusion, right ventricular hypertrophy and dilatation. And I think that a good key to diagnosis is the combinations of signs of pulmonary hypertension, signs of pulmonary edema, and small central pulmonary veins. So the patient was treated by gemcitabine, but I only found one previous case report, so maybe it's not very frequent as a complication of this treatment. The second disease is extremely rare. It's what in French we call an Arlésienne. So Arlésienne is a lady coming from Arles, and it's a play from Alphonse Daudet. And during that play, this lady is always mentioned, but she's never going to show up. So the expression for something that we always talk about, but we never see. So what are the specific CT signs? Ill-defined centrilobular nodules of round glass opacity with no evidence or minimal evidence of interlobular septal thickening. Interlobular septal thickening is mostly something that you will see in POVD. And I don't have any cases in my teaching files, so this is an image from this publication. So to summarize, group 1 prime are rare, difficult to diagnose, but there is no room for error because patients with these conditions may develop fatal pulmonary edema if they are treated with vasodilatator agents. So you've got to recognize them. In this part of my talk, I would like to explain how to distinguish between group 1 and group 4 pulmonary hypertension, because it's very important to make the difference. As I mentioned, in some of the group 1 diseases, you won't have any specific sign. It's the case for idiopathic pulmonary arterial hypertension or due to HIV infection. And you must be sure that it's not chronic thromboembolic pulmonary hypertension. I think that we are doing quite well if we see this showing that with the time, more and more patients are operated on. It means that we make the diagnosis thanks to multi-slice CT. This is a case of a patient, again, referred for CTPA for suspicion of pulmonary embolism. This patient has a pacemaker because he has inherited arrhythmia and he complains of breathlessness. And do you think there's PE, acute PE in this patient? Of course not. He has the following 3 specific signs that are related to chronic thromboembolism. Here you have an stenosis of the right lower lobe artery. There is an enlargement of the main pulmonary artery, enlargement of the bronchial arteries, so it's systemic compensation of the obliteration of the pulmonary vasculature. And on the lung parenchyma, you have a mosaic attenuation, and you can see, which is defined by the fact that in areas of low attenuation, you have less vessel, and the vessels are of a small size. And in this patient, only this part of the lung remains vascularized, and also this part. So it's a very severe disease. And last sign, it's pseudobronchial dilatation. If you compare the size of this artery and the size of this bronchus, it's not the bronchus which is enlarged, it's the artery which is very small. So, to suspect chronic pulmonary thromboembolism, you will have to find signs of chronic PE that may have very various appearances, reduction in occluded vessel diameters, eccentric thrombi, pseudo and thickening of the arterial wall. Arterial stenosis and MIP reformation is quite helpful. Pouching defect defined as an abrupt interruption of the vessels, and bands or webs corresponding to fibrotic material within the arterial lumen. The second group of signs refer to systemic collateral supply with enlargement of bronchial systemic arteries, and you will need to use coronal MIP reformation to easily identify these bronchial arteries. And sometimes there is enlargement of non-bronchial systemic arteries, such as internal mammary arteries or phrenic arteries. Third group of signs, mosaic attenuation, as I mentioned, a difference in the number of vessels and in the size of vessel between the areas of increased and reduced attenuation. Mosaic attenuation can be quite subtle. If you look at this image, maybe you won't notice anything. And it's important to use minimum intensity reformation, but you will have to do that on the soft kernel reconstruction. And here you can see that there is a very marked mosaic attenuation in this patient. And this is the case of another patient before and after pulmonary endarterectomy. What are the potential pitfalls? We can confuse between eccentric thrombi in chronic thromboembolic pulmonary hypertension and in situ thrombin formation in long-standing pulmonary hypertension of other origin, especially Eisenmenger syndrome or portal pulmonary hypertension. And also, we can confuse between mosaic attenuation due to pulmonary hypertension and due to chronic thromboembolic disease. The key point is that in situ thrombus formation only occurs in cases of aneurysmal dilatation of the central pulmonary arteries. Here, this interlobular artery is not enlarged, so it's not in situ thrombus formation. This is chronic thromboembolic PH, this is Eisenmenger, and this is portal hypertension. But sometimes it's difficult. This is the patient with Eisenmenger, and this is chronic thromboembolic disease. Regarding the mosaic attenuation, it's mainly peripheral and limited in pulmonary hypertension of non-thromboembolic origin. It is due to distal vasculopathy, and you won't have large areas of mosaic attenuation if it's not due to chronic to thromboembolic origin. This is a 19-year-old woman with severe pulmonary hypertension. I will ask you your diagnosis. Is it chronic thromboembolic pulmonary hypertension? Is it idiopathic? Is it due to HIV? Is it of other origin? What do you think? It's of other origin. It's a patient with vasculitis. You have distal stenosis of the pulmonary arteries, and it belongs to group 5 diseases. In this 35-year-old woman with severe pulmonary hypertension, do you have an idea of the disease? Is it systemic sclerosis, idiopathic, PVOD, or CTEPH? Because of this thickening of the interlobular septa and central ground glass associated with signs of pulmonary hypertension and very small central pulmonary vein, it's PVOD. That is the correct diagnosis. So, to summarize my talk, in idiopathic, irritable, HIV-induced or anoxygen-induced diseases, there are no specific signs and only signs of pulmonary hypertension. Specific signs can be found in Eisenmenger, the signs related to the shunt, in portal hypertension, signs of portal hypertension, in systemic sclerosis, signs of infiltrative lung disease, and in PVOD, pulmonary edema with small central veins and signs of pulmonary hypertension. It's especially important in this group of disease to be sure it is not CTEPH, because in some patients, signs of chronic PE can be quite subtle. thank you for your attention, and I hope that you will attend the ST meeting in Amsterdam in June. Thank you.